Teresa, may I do a voice check?
Absolutely, and I can hear you wonderfully.
Am I loud enough?
Yes. I can hear you really clearly.
Okay, thank you.
Thank you. Good morning, good morning. We have about 5 minutes before we get started. Thank you all for joining. If you could take a moment to put your name and organization into the chat box. And as I stated, we'll get started in about 5 minutes. So thank you all again for joining. Great. Good morning, good morning.
Good morning, everybody.
All right, we're gonna try to start at 10 a.m. on the dot. So while you guys are here, if you could please put your name and organization into the chat box. And as I stated, we'll start in about 2.
Is Gail here and Dr. Lisa?
Yes, I can hear you, Dr. Hazel.
I may have to leave at 10 o'clock. I have a meeting with some patients.
Okay, okay, we completely understand. Thank you for jumping on.
Thank you.
I hope everyone is staying warm out there. It is cold to me this morning. And if I could just get a thumbs up, can everyone see my screen? Awesome, thanks, Julie.
Good morning, Torlisa.
Good.
Hey, good. Good to see you, buddy.
Again, as everyone is joining, if you could take a moment and put your name and organization into the chat box, that would be wonderful. It is 10 a.m. And so we're gonna go ahead and get started. First, I wanna thank you all for joining. My name is Terlisa Hall. I am a program manager here at the American Cancer Society, and I am a co-lead for the Texas HPV Coalition. We're gonna quickly give you an overview of the coalition as well as what we're doing this week. before we just jump into our great speakers, we have some really great speakers for you all today. I'm really excited to hear from everyone. But our 2021 annual HPV Vaccination Summit is being held today, December the 7th, through Friday, December the 10th, from 10 a.m. to 11:30 a.m. Central Standard Time each morning. And we ask that if you are available, please join us. We're excited about this week and all of the great things that we have to hear and learn from experts in the HPV world from all over, not just the state, but also the country. So we're really excited about what we have planned for you all. So as we all know, the HPV vaccine is cancer prevention. That is our focus. We know that the vaccine prevents 6 different types of cancer, including cervical, vaginal, vulvar, penile, anal, and throat cancer. This vaccine is safe and effective. More than 100 million doses have been given out over the past 13 years with no adverse side effects. And this vaccine is for both boys and girls between the ages, and it can be given between the ages of 9 and 12 years of age. At that point, it is a 2-dose series. So our mission with the HPV Coalition is to build collaboration, enhance communication, and work across Texas to increase HPV vaccination. So we're able to do that through our 4 work groups. Those work groups are provider education, data and technology, systems improvement, and advocacy and awareness. The special thing about our summit this year is we were able to let our work groups take the lead on the direction they wanted to go and with the summit this year. So each day is going to be led by one of our different work groups. Today, we're going to be led by our provider education work group. This work group is led by Dr. Lois Ramondetta, who is with the MD Anderson Cancer Center. You'll be able to hear more from her later on in today's session. And just to cover a couple of projects or a few projects that this work group has done over the years, we've had an HPV team-based learning module that was in Texas Medical Schools. That project was led by Dr. Ramondetta. We've done a school nurses lunch and learn this past summer. We had a project that focused on dental provider education that was led by Dr. Rhonda Stokely, who is with the Department of State Health Services here in Texas. She led dental provider surveys and presentations for dentists about the HPV vaccine. We also had a back to school webinar, which featured some of our guests from today who were able to provide great information to parents, educators across the state about the HPV vaccine, and not just the HPV vaccine, but school-based vaccines as we prepare to go back to school in the midst of a pandemic. So we've really done some great work. We've seen some great projects through the provider education work group. So we're really excited about what we'll be doing today, as well as what we'll be doing, what this work group will do in the future. So the composition of the Texas HPV Coalition looks as so. We have about 75 members on our roster. Those members come from various types of organizations. Many come from research and research institutions, universities, nonprofit organizations such as the American Cancer Society, the Immunization Partnership, the Department of State Health Services, local health departments, and health systems. So we do see a variety of members that work with us and help us achieve our goals with the HPV Coalition. When we look at how engaged our members are, it's kind of even across the board. So it's evenly distributed between high, medium, low, and none. High means full engagement, right? They're attending multiple meetings. Right now, they're all virtual, but they're either leading or participating in our work groups, participating in our projects. Around medium, that would say within the last few years, maybe they've attended a couple of meetings or had attendance in at least one. And then low to none means there was minimal engagement with the coalition. We are hoping that as we move forward, we know the pandemic really did kind of put a hitch in what we were doing with the coalition. And so we're looking forward to the year 2022, where we can begin to be active again, get our work groups back together, start back meeting, and actually get some new projects planned and work and going. So we're really looking forward to getting that level of engagement to more so on that medium to high side and in what we're doing in our members, in our membership. 2021, our goal was to reinvigorate the work group, reinvigorate the membership, the coalition as a whole. We're always looking for interested people who want to be active in this work. If you would like to join the coalition, please feel free to reach out to myself or my colleague, Rachel Coughlin, and we'd be happy to give you more information on the work that we're doing. Our website is up and running, and so if you would like to check it out, we'll provide the link to that. But we have a lot of goals, and we're really excited about what the future holds for the Texas HPV Coalition. Here we just have a few of the organizations that are a part of our coalition. As you can see, I think I named a few of these, but some that I may not have include the Texas Medical Association, Texas Pediatric Society, MD Anderson, UT Southwestern. There's over 40 organizations that are represented on our coalition right now, but these are kind of the organizations that kind of predominate the work with us. All right, again, if you want to join the team, our next meeting is going to be held February the 10th at 10 a.m. Central Standard Time, and just again, feel free to reach out to me and I'd be happy to provide you more information about the coalition and the great work that we're doing. All right, so as we prepare to get started, and I want to apologize now, we're going to do that introduction for each day, just in case there are new people who join on each day. That introduction will be provided, and each day we'll just highlight each work group that's going to be leading the session for the day. Today, we're going to hear from Dr. Erika Thompson. She's going to provide an HPV 101. Following Erika, we're going to have HPV considerations, which is going to be led by Dr. Celia Neavel. Following her, we'll hear from Karen Swin, who's going to talk to us about the American Academy of Pediatrics grant. Following Karen, we're going to hear from Julie Bazan about the impact of You Are the Key training on HPV immunization rates. And then there's a poll that you're going to be introduced to during the HPV 101, and we're going to actually review that after we hear from Julie. And then we'll hear from Dr. Lois Ramondetta on influencing the influencers. Okay, so thank you so much again for joining us today. I hope you're able to join throughout the remaining of the week. And I'm going to now pass it over to Dr. Erika Thompson. And I'll stop sharing my screen.
Thank you so much, Trelisa, for the introduction. Just going to go ahead and pull up my slides. Can everyone see that all right? Okay, great. Well, thank you so much for the opportunity to represent the Provider Education Work Group. We're excited for our session today. As Trelisa mentioned, I'm Erika Thompson. I'm an assistant professor at the University of North Texas Health Science Center, School of Public Health. I do also want to mention that I'm a consultant for Merck with a contract through the Health Science Center, but it's not related to this work today, and I have no other conflicts to disclose. So in this brief presentation, we'll do HPV 101, and I know Trelisa already covered some of these topics, and I'm sure many of you are familiar with these concepts. But the main reason we're here today is because HPV causes cancer, and we all are part of that mindset of wanting to prevent HPV-related cancers. So on the screen here, I have kind of these pie charts that describe what proportion of the different cancers at these different sites are caused by HPV. So it's an HPV attributable cancer where it's probably caused by HPV. So these are anogenital cancers. The most common we think of is cervical, but also oropharyngeal cancers, which tend to happen at the base of the tongue and in the tonsils. Now, when we think about those cancers and what the burden of that cancer is in the United States, we can see based on these data of HPV-associated cancers, these are types of cancers that are happening at the sites where HPV can occur. And these data come from cancer registry data to estimate the number of HPV-associated cancers. We see that each year about 45,000 new cancer cases are found at the parts of the body where HPV is often found. For females, that's about 25,000 cancer cases, a majority at the cervical cancer. And for males, just under 20,000 cancer cases per year, a big majority of that being at the oropharynx. If we think about the proportion that we saw in the last slide, like applied to these numbers of cancers, it's estimated that HPV causes about 35,000 of these cancers, and that's about the size of an average attendance for a baseball game. So that's a significant burden of disease. Another way we can look at these numbers is the number of HPV-associated cancers per 100,000 persons, so as a rate to help adjust for the population size. So this dark blue bar on the left-hand side represents the overall rate in the United States. That's 12.3 per 100,000 persons. And then we can see it broken up by men and females and males. So females at a higher rate at 13.8 in that teal color, and males that lighter blue at 10.9. And for males, this is again predominantly due to oropharyngeal cancer rates at 8.7 per 100,000 persons. And for females, predominantly due to cervical cancer at a rate of 7.2 per 100,000 persons. And we often think that when we think of HPV and cancer, cervical cancer is what comes to mind. But we know based on data from HPV-associated cancer trends in the US from 1999 to 2015, we've seen a shift where oropharyngeal cancer has actually taken the lead compared to cervical cancers as of 2009. So we've been fortunate to see a decline in cervical cancer rates over time, but at the same time, which is indicated by this dark blue line, solid line, but at the same time, we've seen a rise in oropharyngeal cancers as indicated by this dotted line. So that is becoming more and more worrisome. Now let's take a quick moment to look at what's happening here in Texas. So on the left-hand side, you can see that the HPV-associated cancer rate in Texas for 2013 to 2017 is at 11.7 per 100,000 persons, so lower than nationally, which is great news. Unfortunately, though, our cervical cancer incidence rate is higher than the United States rate, so still some room for improvement there. We can also break out these rates by sex and race ethnicity. These incidence rates were higher in females, which is seen on the right-hand side in red, so much higher compared to their male counterparts, which is seen in blue. And among males and females, non-Hispanic white folks had the highest incident rates, but also relatively high rates among non-Hispanic Black, Hispanic women, as well as American Indian, Alaskan Native women. And finally, the last data figure for HPV-associated cancers that I'll share is to look at our public health regions here in Texas. So you might take a moment to figure out where you are sitting at in terms of the public health regions on this map. But the highest incident rates that we see is in Region 2, which is next door to where I'm at today. And for regions 1 through 5 and 9, the incidence rates of HPV-associated cancers are above the state average. So how do we go about preventing these cancers? And as Teresa mentioned earlier, and why we're all here today, HPV vaccination. So the HPV vaccine can protect 9 types of HPV, including 7 types that cause cancer. In fact, HPV vaccination could prevent more than 90% of cancers caused by HPV from ever developing. And it's estimated 33,000 cancer cases in the US every year could be prevented. We also know that these are safe vaccines with more than 135 million doses being distributed in the United States, and there's robust data to show that these vaccines are safe. So the priority group that we focus on are those adolescents recommended for routine vaccination ages 11 to 12, but we're seeing more and more shift toward that early start at ages 9 or 10. There's also opportunity for catch-up if someone's not adequately vaccinated until age 26. So we think of our older teens or young adults. And then most recently, we've seen the CDC recommendation for a shared clinical decision for adults ages 27 to 45 who aren't adequately vaccinated. Now, let's look at some of the great evidence supporting the impact of HPV vaccination that have come out globally. This is a lot happening on the screen, but this figure shows data from a Swedish study of girls and women from 2006 to 2017 with over 1.5 million people ages 10 to 30. The big take-home message is this study found an 88% reduction in cervical cancer risk among young adult women vaccinated before age 17, which is on your screen here in this orange group, this vaccinated line, compared to the green line, the unvaccinated group is the orange line, the vaccinated group is the green line. So significant reduction in cervical cancer, and similar for those who were vaccinated between the ages of 17 to 30, we saw a 53% reduction in cervical cancer risk. We also recently had a study come out from the UK's National HPV Vaccine Program last month, where we observed a substantial reduction in cervical cancer and incidence of CIN3 in young women after the introduction of their vaccine program in England, when it was offered to girls ages 12 to 13. So overall, this modeling estimates that 448 fewer cervical cancer cases and 17,000 fewer grade 3 cervical intraepithelial neoplasia, or CIN3, occurred in these vaccinated cohorts. So really fantastic success and data showing the impact of HPV vaccination. And these successes align with the overall global goal of cervical cancer elimination set forth by the World Health Organization's cervical cancer elimination goal, which is to get to an incidence of 4 or fewer new cases per 100,000 person years. And this was announced in 2018 and is an ambitious attempt to reduce cervical cancer through 3 pillars. One being vaccination, the second being screening, and the third being treatment. Now, you may be saying incidence of 4 per 100,000. We're about double that right now here in Texas, so still some progress to be made. But according to a modeling study by Berger and colleagues, they found that the US is on track to reach this goal between the years of 2038 to 2046. And we could potentially speed up this goal by 10 to 13 years if we buckle down and really focus on screening efforts. So great opportunity here in terms of cervical cancer elimination. But let's take a look at how we're doing in Texas for some of these prevention strategies. So these data come from the CDC, from the National Immunization Survey team, and it's showing the percentage of our adolescents here in Texas as of 2020 who had at least 1 dose of the HPV vaccine. So for females, that's about 76. For males, that's 70%, pretty similar to what we see nationally for those numbers. So we've made significant progress in the past few years. And if we looked at up to date for the entire series, so either 2 or 3 doses, and this line is indicating when we made the switch in 2015 from 3 doses to 2 doses to be considered up to date, we see that just over half of adolescents in Texas are up to date on their HPV vaccines. Unfortunately, because of the COVID-19 pandemic, we're seeing some regression in terms of the number of children up to date on their adolescent vaccination. These data come from the Vaccines for Children program, and in 2020 and 2021, saw a reduction of 18% in the number of immunizations provided compared to 2019. There have been similar studies that have been done by Saxena and colleagues that have shown similarly with insurance claims data, significant reductions in adolescent vaccines, and projected that it may take to catch up the winter of 2023 to fall 2031 to make up progress for what we've missed in this past couple years. And as I mentioned earlier, it's not just vaccination, but we also have screening involved. Unfortunately, though, it's just the tip of the iceberg in terms of screening for HPV-related cancers, since it's predominantly cervical cancer and cervical precancers that we're seeing. Even with screening, HPV causes 11,000 cases of cervical cancer each year in the US, and 4,000 women die of cervical cancer. And if we look at national data, unfortunately, there has been a decrease in women who are up to date with their cervical cancer screening at a national level. These data come from the National Health Interview Survey, where it's fell to about 3 out of 4 women being up to date on cervical cancer screening, well below the Healthy People 2030 target of 84%. So significant progress needing in this area, and unfortunately also seeing the impact of COVID-19 on screening. This figure is showing data from the National Breast and Cervical Cancer Early Detection Program that provides services to women with low incomes or inadequate insurance coverage. This blue line indicates 2020 data compared to the gray line of 2019 data, and you can see during those periods of lockdowns early in the pandemic, a significant decline in cervical cancer screening services. So you're about to be part of a 4-day summit and hear from a lot of groups, and one of those being today with our provider education group. And we really are hoping to hear from all of you in terms of how we can address some of the barriers to HPV vaccination here in Texas, as well as what can we do moving forward as a work group. So we're going to ask you, I put in the chat a link to a Padlet. And if you're not familiar with Padlet, this is something fun that many of us have discovered through Zoom calls in the pandemic. But it's basically a board for everyone to contribute to, where you can click on one of these plus sign icons to add a comment. You can like comments by clicking on the heart, but really it's a way for you to engage and share feedback with us. So I'll continue to do nudges in the chat for folks, and then toward the end of the session, Laura and I will be going through and summarizing some of the key feedback. So we really appreciate any feedback that you all have to share with us, and look forward to talking a little bit more with you all. So thank you all.
Thank you, Erika. Thank you so much for providing that great overview of HPV and the HPV vaccine. So we are now going to move over. I want to apologize. I did misspeak as far as the order of today's session. So we're next going to hear from Karen Swind. Let me share my screen. And Karen, can you hear us? Or can you hear me?
And
Awesome. All right, Karen.
I can see slides. That's great. Thank you all. Your words have weight. Promoting the HPV vaccine is the title of our presentation today from the Educator Providers Work Group. I'm Karen Schwind. I serve as the president of the Texas School Nurses Organization, as well as the Health Services Coordinator for New Braunfels ISD. And I've been working with the coalition since its beginning. I'm not sure we actually discovered a year for that, but Teresa, you can probably speak to that. It's been a while, and I'm honored and I'm proud to be here. Next. A little over a year ago, I was approached by the Texas Pediatric Society to be a sponsor with TSNO for a grant from the American Academy of Pediatrics. This grant was a collaborative effort between the Texas Pediatric Society, the Immunization Partnership, and the School Nurse Organization to provide statewide HPV and influenza immunization rates. This was just prior to the outbreak of COVID. So of course, HPV, influenza, and COVID were all included since those are the non-required vaccines. The primary purpose of the collaborative was to support developing and implementing plans to reach rural and underserved populations within the state of Texas. Texas was one of the states that was awarded this grant, one of 6 states. So I was very pleased and honored to be able to work with these organizations to provide education and information to our underserved populations. Next. We broke this out in a series of 3 webinar presentations, again, with the institution of all of the Zoom calls with the pandemic. We changed our gears and focus. And the first one was Immunizations 101. We focused on the basic immunizations and laws, and primarily targeted our freshman legislators to let them know what immunization laws are, so that when they're approached by those who support immunizations or those who don't support immunization, they would have the facts on what immunizations are and what the laws are surrounding those. So Allison Winky and Jason Turk presented an overview of immunization recommendations for lawmakers and addressed the access barriers, identified the vaccine efficacy, and explained the Texas Vaccine for Children's program. Those of you that are administering vaccines, you know all about that program, but for some, especially legislators, we felt it important that they review that information. We also reviewed data and recent spikes in the vaccine preventable diseases and the decrease in vaccination, as Erika has mentioned, and providing insight on community immunity. That presentation was done in April. Next. And then in July, a collaborative effort between Dr. Turk from the Texas Pediatric Society and Hill Powell from the Immunization Partnership and myself presented to superintendents, school nurses, health departments on the effects of COVID-19 pandemic on school-age immunizations. Next. This was broken out into 3 topics, with Dr. Turk being our primary subject matter expert, reviewing COVID, the impact on school-age immunizations for both required and non-required vaccinations. And as fellow school nurses who may be on the line, we did see that at the beginning of the school year, that many of our students were behind on some of their immunizations due to the pandemic, again, as Erika mentioned. Also the importance of the flu and the HPV vaccinations, especially during the time of COVID. Hill Powell reviewed the immunization recommendations and barriers to care. Also the growing problem with non-medical exemptions in schools, as we've all seen across the state of Texas, an increase in the conscientious objections that parents are submitting. And then lastly, we talked about the importance of immunizations for school administrators. There's quite a difference in districts and even in regions. Some districts say no shots, no school. If your immunization record is not up to date, you do not have a seat at school, where others allow the students to come to school, and then it becomes a tracking to be able to identify those kiddos that need to have their immunizations up to date. We also included the importance of those non-required immunizations. As an example, I have a nurse who's out on leave, and I just was faxed a record to review for a new student. And they are compliant. All of the required vaccinations are up to date, but they've received their first dose of HPV and not their second dose. So I was able to type and reply, my mom is there at the school enrolling the child, that they are up to date with their current registration, but they are in need of that second dose, and they need it now. So that's an example of how we might promote those vaccinations. Also to raise awareness in schools and provide resources on clinics that we might see be brought to the school, particularly at the 6th grade level, to offer the opportunity for those who need the required vaccines and to bundle the HPV with those required vaccines. Next. And then lastly was a project in conjunction with the American Academy of Pediatric Grants, but also at the same time I was working with Efrat Gabe and Paula Caraco from the All for Them program. And so we were able to offer a combination, a collaborative effort in a webinar specifically targeted for school nurses. And I have the link here. If any of you on the line are nurses, there is 1.5 CNEs offered for this presentation. And it is a webinar that you can link to here, register for, and complete. This was initiated in November, and I had the great honor of presenting this to our Texas School Nurse Organization conference that took place earlier this month. So I was able to present the All for Them program as well as the information for this webinar from the UT Health Houston Research Center. Next. The topics included the HPV vaccine and why it is important. Much of the same information that Erika had presented this morning and Trelisa had also mentioned. The critical role that school nurses play in recommending HPV and flu vaccine for the students, and strategies to communicate with parents about HPV and the other non-required vaccines. How to become a champion for HPV vaccination, and skills for the entry of HPV recommended vaccinations into the district immunization record. You know, I really do feel that school nurses can play a huge role in having these students not only begin their HPV series with the first dose, but also complete it. We have our hands and on every immunization record for the students as they enroll new to the school. And we also have access to all of those immunization records. Most will run a report that let you know which doses are needed, and you can run that report for HPV as well. So then we also talked about the influenza virus and the current state of flu in Texas. And lastly, heard from HPV-related cancer survivors that were such impactful examples of how important the HPV vaccine is in prevention, and also from Texas school nurses and sharing some of their examples of how they've communicated the HPV need to their parents and students. Next. We plan to continue the grant project. The American Academy of Pediatrics invited our state to continue, and we did apply. And I just heard this morning that we were accepted. So we will again focus on HPV and influenza vaccination rates in the rural and underserved areas. For this next grant cycle, our tentative plan is to target school nurses with education and resource distribution, school administrators, and pediatricians, particularly awareness campaign, and again, resource distribution. Next, my last slide has my contact information. If you have any questions, please feel free to reach out to karenschwinn.tsno@gmail.com. And your words have weight, promoting the HPV vaccine. Thank you so much again for the opportunity to visit with you this morning.
Thank you. Thank you so much, Karen, for sharing with us and sharing some of these great opportunities. I hope that everyone was able to pull them. If there are links that could be dropped into the chat box for some of those classes or sessions, that'd be awesome. Next, we are going to hear from Dr. Julie Bazan, who's going to talk to us about the impact of the You Are the Key trainings.
Good morning, everybody. Good morning, Trelisa. Thank you for the kind introduction. I am not a doctor. I will be soon, hopefully, but I do appreciate that. Thank you, everyone, for sharing your time with us this morning. And I want to acknowledge Trelisa for all her efforts in bringing this together, coordinating all of us with our busy schedules and different projects and all the speakers today. It's a pleasure to join this forum with you. So let's go ahead and begin. Today, my goal is to give you information on a project that we are very much proud of, So let us begin. The next slide will give you the learning objectives for my presentation. Through this presentation, I hope to give you enough information where you'll be able to describe the HRSA for those of you that are not familiar, and the AHEC program, define the goals of the Mid-Rio Grande border AHEC, discuss the National AHEC Organization HPV project, and hopefully recite the evidence from the pilot study that we conducted. On the next slide, you will see the HRSA AHEC program. The Area Health Education Center, also known as AHEC, was established in the 1970s, and the Health Resources and Services Administration is the primary funding for this wonderful program. Although it was created in the early 70s, today there are over 200 AHEC programs in the United States. And you can see here from this slide, the goal of the AHEC program is to build education and training networks in the different communities by collaborating with the existing healthcare resources, higher education institutions, and partners that believe in the mission of the Area Health Education Center. We particularly focus in the rural area. So on the next slide, I will highlight for you the Mid-Rio Grande Border Area Health Education Center. And this program, I am very privileged to be its executive director. We were established in 1993, and we're located along the US-Texas-Mexico border. The mission of the AHEC, of the Mid-Rio Grande Border AHEC, is very specific, and it tries to increase the number of healthcare providers in our region, enhance the academic resources for our providers, and foster a healthy lifestyle for all residents in our community, in our service area. And in the next slide, you will see the Mid-Rio Grande Border Area service area, which is composed of 6 counties. You will see that it's Dimmitt, LaSalle, Duval, Zapata, Jim Hogg, and Webb being the largest county. We are 91.9% Hispanic. We are a medically underserved rural area. So how do we accomplish our mission in these different areas? In the next slide, you will see that throughout the year, the Mid-Rio Grande Border AHEC conducts activities and programs catered specifically to the practicing providers in the region. And we have several projects that we do on an annual basis, one of them being the annual Update in Medicine Conference. Here's a slide sample of the flyer that we utilized this year. It was a virtual conference, and this has been going on for 37 years. This is the only event of its kind in the region that provides continuing education for providers in different specialties. We also offer the Binational Health Conference, which is a binational health education initiative where we have providers from both sides of the US-Mexico border attend this one day filled with information and knowledge. And we do offer this annually, as well as the Domestic Violence Conference. I showed you on this slide the information of the some of the flyers that were developed and how we continue to provide these services to our providers in spite of the pandemic. We offer virtual accredited programs. On the next slide, you will see some of the information that I was able to capture in one slide to show you how we serve our students, because since our mission is to increase the number of providers, we determined years ago that in order to grow our providers, we must grow our own providers, meaning introducing our students to the many healthcare options, career options they have, as well as continue to motivate them and educate them about different topics that impact their life. The most recent one, we all know, the COVID-19 pandemic. So in addition to that, we provide information and education on how to prevent domestic violence and dating and the different settings, as well as what to do if they suspect that someone needs help. Since May of 2020, we have been conducting virtual mental health gatherings twice a month, and our students are invited, as well as the community members. So we support our students in different ways. So here, this slide, you can see some of the flyers developed, some of the hands-on activities, and in addition to that, their service to the community while they learn about different agencies and resources to help our community members. As future healthcare providers, they must be knowledgeable about what exists in our community and where they can refer someone that they encounter that needs help. On the next slide, you will see just a brief a snapshot of some of the activities that we provide for the community as a whole. The idea is to educate and empower community members with critical information on health topics so that they can make informed decisions for them and their families. We also offer year-round health fairs, participate in different events that create awareness, like the Alzheimer's Awareness Walk that was conducted recently, but most importantly, special topics like the HPV vaccine. We held numerous town hall talks, town hall gatherings, where we invited parents, families, and teenagers to learn about the HPV vaccine. So I gave you, on the next slide, you will see what we're here to tell you about today. So we talked about some background on the HRSA that created the AHIC. I gave you information about the mission of the AHIC, and I also specifically went into detail into some of the things that we at the Rio Grande border AHIC do to serve our communities. So now that we have come this far, this is really the information that supports the documentation and the data presented to you by Erika and Karen in the earlier presentations. Let me review the National AHIC Organization Human Papillomavirus Vaccine Project. This project was funded by the Centers for Disease Control. So on the next slide, you will see the background of this project. The National AHIC Organization and other organizations use the CDC Cooperative Agreement grants to focus on raising the HPV vaccination rates. The NAO and the AHICS network provided provider trainings to increase the vaccination rates in many parts of the country. The evaluation of these trainings found that increases in awareness, knowledge, and skills among the providers did exist. However, whether these training programs increased the vaccination rates was unknown. So on the next slide, you will see what the program itself entailed. The program entailed providing training to medical providers using the You Are the Key materials developed and provided by the Center for Disease Control. And the goal was to increase awareness of the HPV burden, as well as provide knowledge of CDC vaccination recommendations, and increase the skills and approaches to help parents decide to vaccinate their children. This included recommended practice changes to increase the HPV vaccination rates in the primary care practices. That's what the purpose of this training project entailed. So on the next slide, you will see that in September 2017, the National AHIC Organization HPV Immunization Project completed 3 years of training providers in many parts of the country. But there were still questions in our minds. So a team of individuals, and you can see the authors of this research project, conducted an evidence gathering project to answer our question, does You Are the Key training increase the HPV vaccination rates? On the next slide, you will see that the main purpose of the study was to determine if the HPV vaccination rate data can be collected from providers, because as all of us know, providers are very busy and there's so much going on day in and day out. Identify the challenges to obtaining the data, identify barriers to providing vaccinations, and see if pilot data shows an increase in the vaccination rates at that provider's practice. On the next slide, we can review the methodology that was utilized to obtain the data, and it is listed here. The methodology included recruitment of some of the trained providers who received the You Are the Key training in 2016 and 2017. The recruited providers share data on the total number of 13 to 17-year-old male and female patients in the 6 months before the provider received the training and 6 months after they received the training. The data included the number in each time period of those who completed the HPV vaccination series. On the next slide, I will show you the results of this. The results of this study were surprising. And let me tell you that the reported data gave us a count of 2,174 13 to 17-year-old patients seen before and 2,071 13 to 17-year-old patients seen after the training. And that was the data that we were able to acquire from some of the providers. The providers recruited into the program, and the providers were recruited from the Rio Grande border area health education center and the Louisiana Area Health Education Center. So those that completed the vaccine for girls increased from 40.6% to 61.1%. For boys, it increased from 32.4 to 56.1. For all 13 to 17-year-old, the completed vaccination rates increased from 36.3 to 58.7%. So these are just numbers, but they are numbers that definitely can tell you a lot. So if we go to the next slide, you can see a graph that'll give you a better picture of the vaccination rates, where we were before the providers received the training, which is the yellow bar, in the boys and the girls. And then, of course, the green bar is for after the training. I also want to point out to you that the green line that you see there, the dotted line, is the national vaccination rate. So this tells us that our pilot study, not only did it increase the number of 13 and 17-year-old that completed their vaccination series, but we exceeded the national vaccination rate on the HPV vaccine among the 13 to 17-year-olds. And so we were very, very happy to see this type of result in our small study. So if you go to the next slide, you will see in the summary that we discovered that You Are the Key training does in fact provide new knowledge and continuing education for providers. It created awareness about cancer prevention for everyone, and it showed an increase on HPV immunization rates. Our pilot study was done 2 different years, and we compared the data on both years, and of course the data showed a significant improvement in the vaccination rate. So this was very satisfying for us, because we understood that the training was definitely impacting our communities in preventing cancer, creating awareness, and more importantly, promoting the effectiveness of the HPV vaccine. And that is my presentation. And I know that I kind of went quickly in some slides, but of course, if you have any questions or need additional information, let us know, and we'd be more than happy to help you. I introduced to you the team of the Metro Grande border AHEC, and here's our contact information. We are very, very proud to serve our entire 6th region that is all located in a rural area. And like I said before, all the work that is done simply because we have excelled in developing networking and working in a collaborative manner with people, not just in our community, but throughout the state and the nation. So I thank you for your time today, and thank you for having me be on this forum. Thank you so much.
Thank you so much, Julie, for sharing such great work that you all are doing. It's so amazing to see that significant change in HPV vaccination rates. That's amazing. So thank you so much. I did want to quickly add, we will do a Q&A after we do our polling, after we talk about the polling questions, and Dr. Ramondetta speaks on influencing the influencers. So if you have any questions, please hold on to them until we get closer to the end of today's session. Next, we are going to hear from Dr. Neavel along with Myra Sanchez. Dr. Neavel, can you hear?
Yes, I'm trying to start my video, but I wonder if you need to start it.
Yes. Oh no, is there any way for you to turn your camera on?
Yes, I'm trying to, but it's not going on.
Oh, no. Okay.
If it doesn't work, I guess we'll just go through the slides. And my medical assistant was going to try to join, but I'm not sure if she was able to log in or if is doing some things with patients, but we can get started.
I'm here.
Hey, Myra.
Hello, good morning.
Did your camera work?
Let me check.
Okay, for some reason mine's not.
Yeah,
there you are.
Works.
Okay. Cool. All right. Well, we're happy to be with y'all. We are providing more the grassroots, I think. So we've had some speakers talk about more data and policy, and we're going to talk about what goes on in our clinic. We actually are a Center for Adolescent Health, so we focus completely on youth ages 10 to 24. And so I'm board and family medicine and then fellowship trained in adolescent medicine and developmental disorders and run our Center for Adolescent Health. And Myra?
Hi, I'm the medical assistant supervisor.
For our Center for Adolescent Health. So, all right, so we can start with our first slide. All right, so we wanted to give you all an idea of what it actually looks like in our clinic to be thinking about HPV and our vaccines. So Myra, do you want to start with this?
Sure. So what the MA does is a day ahead, we go ahead and review the chart. We specifically target immunizations, especially for our age group. We make sure that they have the HPV at 11. If they don't have it, we offer it at whatever age they come in. We go into MTRAC, we look at personal shot records, make sure that it's somewhere in there. If not, we offer it. We do let the parent know that an HPV is recommended at 11 for both boys and girls. And then that's when the questions start coming out. Like a lot of the questions we get is like, well, I thought it was only for girls. I'm like, no, it's for boys also. And then the second question that comes up is, well, why do we need to give it so young? And we tell them, I go, well, we want to give it at this age so they can start building immunity. And the biggest question is, well, is it a sex-related vaccine? And we constantly tell them, no, it's not. And that kind of puts them at ease. I'm like, we push it on, it's a cancer preventing vaccine. That's what we say in order to motivate the parents to have their kids get this vaccine. And then once they say yes, we go ahead and give it and we document it in the chart and have them come back for their second vaccine when it's time.
And I know now that some of our visits have been virtual, and we sometimes do part of our Texas Health Step visit virtual, we always need to make sure that we bring up vaccines, and we've gotten creative and flexible with that. So sometimes we'll have patients come in just for an immunization visit with our MAs. Sometimes I'll pair a lab visit with an immunization visit. So we try to be flexible in making sure, as was mentioned earlier, we know that it's been more challenging during the pandemic getting people actually in person in the clinic to get their vaccines done. But we're trying to be flexible about that as much as possible. And we really do appreciate all the work that the MAs do, because honestly, it's very smooth for what we do as providers once we go in. But there is a lot of work in prepping the charts, constantly reviewing the chart, making sure that what's in our EHR aligns with MTRAC. So I know that's a lot of work for the MAs as well, and keeping up with this. So next slide. I'm sure there's going to be more about this during this session, but this is a really great handout, a PDF file, which has got a lot of other really good tips on how to speak about HPV vaccine and answer the questions that families may have as they come in, but we treat it as any other vaccine. And I've heard rumors that not all clinics and providers do that, but we don't make sure that it's something special or different. We just roll it in with all the other vaccines that we give and make the assumption that our parents are going to want these vaccines for our kids. So we don't single it out as anything special. And I think that's part of the reason why we've had good success with this. I don't know if you feel that way, Myra, but we just make it part of what we do. So.
Yeah, we always say this is what 11-year-olds get. They get a Tdap, MTV4, and an HPV.
Yeah. All right, and then I decided to focus a little differently because of the work that we do with adolescents. These issues come up a lot with our MAs and our staff about how are different consent issues playing out when we talk about vaccines. So we'll try to get through this pretty quickly. So next slide. Okay, so we're going to talk about vaccines and consent. Next slide. So Minors, about minors consenting to their own health care, there are many factors that we consider within this. So in general, guardians, parents have the right to consent for their children under the age of 18 for vaccines. However, there are specific conditions within the Texas Family Code when minors can consent for their own health care. And it's important that everyone's aware of this. So one, if someone's under 18 and they're legally emancipated by the court, they can consent to their own health care. If they're married, if they're serving in the armed forces. And then a very important one is that youth that are 16 and older and living on their own and managing their own finances, even without parental permission, then they are medically emancipated for purposes of healthcare and can consent for their own healthcare. Texas does not have mature minor doctrine, which is generally starting at 15, but it's a state by state when minors can consent to certain things. Next slide. So, and we also know that non-parents or guardians can consent. And that comes up as well in a lot of our families and the different situations with families that we face right now in our culture. So if a parent or guardian cannot be located and has not given notice to the contrary, then a child's grandparent, adult sibling, aunt, or uncle can consent to medical care. The parent or guardian also may provide written authorization to another adult, and schools may provide care with written authorization. And then there's special provisions for youth in the foster care system or juvenile justice system. Next slide. So in Texas, minors can consent to emergency care, screening and treatment for diseases that are reportable to the state, which includes a lot of STDs, but also things like Hep C and tuberculosis, non-prescription medications, prenatal care and delivery. So anything around the pregnancy or parenting, then they can consent. So we know that pregnant people do consent to like the Tdap, and they can do that even if they're a minor. And then pregnant or parenting minors may consent to certain immunizations, but unfortunately not HPV. Minors can consent around substance abuse, suicidal ideation, treatment for abuse, and psychiatric care. And it is noted that this care is not required to be confidential. All right, next slide. When we talk specifically about immunizations in minors, so again, going back to that Texas Family Code, minors who are parents and have their own child in custody can consent to any vaccine starting before the age of 7. And the idea is to protect the child or cocooning. And I will say that this was something I helped happen through my work with the Texas Medical Association and the Texas Pediatric Society several years ago. And a lot of people may not be aware of this for other vaccines, but the meningococcal and HPV is not part of this since it doesn't directly affect the teen parent's own child. And again, other adults can consent as fits the Texas Family Code, but it's very important to note that we as providers cannot knowingly go against parent or legal guardian. So for example, I had a grandparent bring in a teenager. She was about 16. She was wanting to get vaccines, but I knew that the parent didn't want their child to have vaccines. So I did not go ahead and give the vaccine, even though that minor child and the grandparent wanted it, because I knew that the actual parent legal guardian did not want it. It is important though, in these situations, when you're seeing parents that aren't going to consent for their child, but that you know the child would like the vaccine, is to let them know that once they turn 18, then they can consent for their own vaccines, and they should get back with you so that you can go ahead and vaccinate them if they're interested in that. And there are special circumstances related to foster youth, and I did want to bring those out because many of us are seeing youth in the foster care system. And I know, Myra, we face this quite a bit with the care that we do with several shelters and agencies and families that have foster youth. Next slide. All right. So it's very important when seeing any youth to figure out who the consenters are, to make sure when you are giving vaccines, when you are dealing with those youth, that you do know who the medical consenter is and what you are able to do in your setting. And so in general, for youth and foster care, a judge gives power to the Department of Family and Protective Services to consent. And they could give that to people that are in the shelter, the staff, to another relative, to caseworkers, and there may be more than one person that they allow to consent. And in some cases, this is also important to know, that a court or judge may allow a youth in foster care who's 16 or 17 to be their own medical consenter, and then they could consent to their HPV vaccine. And then I've cited where those are from. Next slide. So we often have to do these emergency three-day medical exams for youth that are just entering the foster care system. And in general, we are not supposed to be giving vaccines during that visit unless they have specifically obtained guardian consent ahead of time. And then, however, that doesn't count for emergency tetanus vaccine, which is on here. And the exclusions to that, again, would be if you already have parental or guardian consent ahead of time. And I know we're trying more and more to get this if the parent or guardian is involved when the child goes into the foster care system, or again, if the minor is their own consenter. Next slide. Okay, and so youth are supposed to get a within 30-day Texas Health Step visit. And then those would be the times when we would make sure that they are up to date with their vaccines. So Myra, I don't know if you want to comment on any of these situations that we talked about, or how important that communication is and how often that actually does come up.
The one we've had is where the patient wants to get the vaccine, but the parent doesn't. I do tell the patient, like, right now, your parent consents for you, but once you're 18, you can consent for yourself. So you can always make an appointment with us for vaccines. So that's the only thing I can tell them. I do try to persuade the parents. It's like, they're gonna get it in the future. It's better for them to get it while you're here and you're seeing me giving it to them. And sometimes that works.
Yeah, and I feel like we've been fortunate. We work in a federally qualified health center, and the majority of our patients really trust us. And again, that's just a really big thing, that the clinic, the provider, the MAs are really perceived as having these long-term relationships with the patients where there's a lot of trust. And so a lot of times we'll say, we've had these vaccines for our own children. We really believe in these vaccines, and families are very appreciative that we're sharing our personal belief in what goes on with these vaccines. So here's our email information if any of y'all are interested. I know that was a real quick going through some issues we face in a specific adolescent clinic. And I appreciate all of y'all's time. Thanks.
Thank you, Dr. Neavel and Myra, for sharing with us. We do have a couple of minutes, so I want to take a moment in case Dr. Neavel has to leave. Are there any questions for Dr. Neavel or Myra? I want to thank you for your great work and for the services that you're providing. But do we have any questions? I want to give a moment just in case they're unable to stay.
And I think I wanted to add, it occurred to me from what some people said earlier, that I also am a big proponent for school-based clinics. So we have one out in Manor, and I want to say that having a school-based health center and that interaction with the school is really important for vaccines and having our presence there. So I want to really support that. We are still, I saw that question, we are still focusing on 11 and up. You can start younger. It is, and again, that might be something, it's a good point, you might want to think about with your foster youth. So having a history of being sexually abused actually does increase the risk, unfortunately, of minors initiating their own sexual activity at a younger age. So there has been discussion that with that history that you consider giving the vaccine younger than age 11. And that would be starting at age 9. I don't know what different clinics are doing about that in the state. We are still predominantly focusing on 11 and up. Any other questions?
All right, I'm practicing my pregnant pause where I don't just start talking and give everyone time to think. Okay, I see.
Somebody's saying in Houston, they are recommending starting at age 9.
All right. Oh, it's been really helpful. I've actually heard from one of the providers, and I believe Karen worked with him, Dr. Turk. He started recommending the vaccine at age 9, and it really helped him as well with increasing his vaccination rate.
Yeah, I think what we switched patients from PD to adolescent around 10 or 11. And then that 11-year-old, such a big visit. So that was kind of the argument too for when people started at age 11, you kind of batched it that this is such a big, important visit transitioning into this concept that you're dealing with an adolescent. Things are going to be a little different. You're going to be meeting with them alone. But somebody's pointing out that maybe you need fewer vaccines at that 11-year-old visit. So good points.
All right, well, if we don't have any other questions, oh, and I do see, continue to use the chat box. We'll absolutely do our best to kind of bring in what the conversations are in the chat box. If you have not, I hope everyone had an opportunity to use the Padlet link. We are now going to transition over. Thank you again, Dr. Neavel and Myra. We are now going to transition over to those polling questions. So Laura and Erika.
Sure. Would I be able to share my screen and I can pull it up?
Yes.
Thank you. Great. Well, thank you all for your contributions to the Padlet. Laura and I are just going to kind of summarize some of the key points you all shared. And Laura, you can go ahead and start us off.
Yeah, and there's a lot of insight here and nuggets that I think can give us some good material to discuss about how this can help us move forward and how we can focus on some of these topics as a group. In terms of starting with specifically the provider recommendation, because as we've heard, the presumptive bundled recommendation is effective, and yet not providers aren't using it consistently. And so what are the barriers? So someone mentioned on that first one that simply like they're busy and providers don't remember, or they're worried about responses. And Dr. Mary Healy, who's not, I don't see her here today, she's involved with the coalition, she's at Texas Children's Hospital, had a study years ago about, and the main question wasn't about HPV vaccination, but they asked about HPV vaccination. And she actually found in her work that providers were projecting onto parents or anticipating that they would be hesitant, but when they asked the parents, they weren't. And so there was this, that the perception wasn't always on target. So it just is a reminder to always ask, because it's not always going to go the way the provider expects. Although, you know, from the experiences of providers, you could see why they would become burned out on using a presentive recommendation if they kept getting negatives. But keep doing it, because some parents may surprise you. And so just trying to stress that. And then someone said, that as a pediatrician, not to underestimate how many parents it's a barrier just to give so many shots. And someone wrote in another comment that there are now 5 shots at that, potentially at that visit. So it's becoming perhaps even harder to get that in when, you know, there are other priorities, flu and COVID and all these on the other adolescent vaccines. So maybe another push for us to talk about as a group, do we want to recommend starting at 9, or remind providers that's an option, that they can start at 9, and then maybe bring in some clinic directors who've made that push in their own systems to ask their providers to start younger. So we may want to talk about that. Is younger going to help us? And do we want to have more discussion on that, or education around that? And then moving on, and audit and feedback is an implementation strategy that we know effectively improves providers' behaviors on specific topics. So if there was audit and feedback on HPV vaccination, that could be another strategy to remind providers and motivate them that their rates aren't optimal compared to the other vaccines they're delivering. Audit and feedback helps providers compare their rates to other providers in their clinic, so it can generate discussion between providers. So some of the barriers we've seen in our work at UT Health School of Public Health and some of our secret projects, our audit and feedback can be hard if at first setting it up and figuring out how to extract the data from EHR systems. So having tools that can facilitate that. And I'll just make a plug for our own research in the Adolescent Vaccination Project that we've been working on developing. We're with, and I'm one of the PIs actually with Dr. Shigag and Vernon. We've been working on this. So if you're interested, reach out and we can talk about some of the tools we've been developing on that, or we can discuss what others may be doing. So audit and feedback be something we want to talk more about in our coalition meeting, because there are definitely barriers to getting it going, but clinic champions can do this and it can work. Okay, so how can this group work to change provider behaviors to increase vaccinations recommendations using the same way, same day approach? So that's very similar to their other ones, but new comments. The MI training, that's a great idea. I like that. And I don't know if the coalition has resources for that, but that's another one to consider, providing this training and becoming a resource for providers to get this. That could cut across so many behaviors for providers to get that, and then tying that to the bundled approach. So that's a great idea. And I don't know if anyone has any comments so far on any of these summaries. I was just trying to summarize it and then pause and let everyone, but maybe I should pause right here, because that was a lot on provider recommendation and just trying to get that out. The 5 shots was the barrier, and then more provider education, so they understand it's worth their time. And I think that ties into the bundled approach because it's short. You know, it actually is the bundled approach for the presumptive asks providers to not say anything else. Just that's it. There's no conversation. There's no qualifying unless they're hesitant and you need to respond to questions. But so we could, you know, this sensitization and how to help providers with that, I think ties really well to the other comments we've heard. Are there any reactions to this or new ideas this triggered for people? Or thoughts so far on our role in helping providers with this communication?
Well, and folks may be putting things in the chat, or you can definitely add to the board. And I know we're getting tight on time, but thank you for that summary, Laura.
Yeah.
And
Yeah, do you want to do the last two columns? I don't know if there's some other ones about rural populations, and access.
yeah, so it looks like some great ideas with regard to expanding the types of providers we're talking about. So
Mhm.
not just MDs, DOs, including family physicians, so not just pediatricians who are great vaccinators.
Mm.
It looks like some ideas that might be a systems work group issue. So with stocking the vaccine, as well as community-based vaccine delivery. So it kind of expanding beyond the pediatrician to some other groups. And also that needs assessment for rural providers could be an out-of-the-box idea for the provider education group to explore. And thank you to those in the chat who talked about some of the vaccine hesitancy from the COVID vaccine spilling over to HPV.
And one thing that I'll just add that seems to be an emerging barrier also, and another source of resistance for parents that we're seeing in some of our research, is social media is increasingly a role in creating more hesitancy and resistance and questioning the vaccination and HPV vaccination. So that may be something emerging that we want to talk about in this group.
All right, I think we have some really great ideas here. Thank you, Erika and Laura, for such an engaging opportunity and for allowing us to share our thoughts. I love the idea of including some motivational interviewing training, reaching out to the rural providers. There's just so much. So we have a lot that we can come together and think about as we move forward in 2022 as to what direction we want to go and what we can do. So thank you all for sharing your great ideas. And thank you, Laura and Erika, for that great overview. We're going to move on to Dr. Ramondetta, who is going to share on influencing the influencers. I'm going to share my screen. Dr. Ramondetta, the floor is yours.
I'm trying to, oh, you already did. Thank you.
Oh, wait, did you want to share?
No, I'm, well, I can, it's fine if you want to just do the next slide thing. That's fine. I was able to get on. All right. Hi, everybody. Wow, this has been a great conversation, and so many people who are working kind of in different parts of the state and doing some amazing projects. And I guess I wanted to I've been really fascinated over the last 2 years with how the COVID pandemic and the approach to the COVID vaccine has impacted me as a provider, as somebody who really was a promoter of the vaccine, the HPV vaccine, because of what I see in the downstream non-infected, the infected result of getting cancer. But I have to be honest, I talked to my survivors about vaccinating their families, but not necessarily about getting vaccinated because they were too old. So all of a sudden I was having to walk the walk in my own clinic. And I quickly learned that managing my state was a key point of talking to people who are vaccine hesitant. So I thought this was interesting about talking about being an influencer, and also the amount of social media influencers that are out there that are, as Lindy said, also, impacting across the board other vaccinations. So next slide, please. So I have no conflicts. However, I will say that my conflict for all of us is that as a physician or a provider, I will prevent disease wherever I can, for prevention is preferable to cure. And I feel like it's my job to do this. Next slide. So this is just, this is a new age and it requires new strategies, and the lines between face-to-face and online virtual interaction are blurring. And, some people do this really well. Many of you have watched some of ZDogg's talks. He's got the great song, More Than Warts. He's got some great discussions that are ongoing and educating people. And he's also done some things that maybe are a little bit more risque, like anti-vax Janet, which is that picture up in the right corner, and can touch people a little bit the wrong way. And we've, these are all opportunities though, Twitter, songs, cartoons, advertisement, and to disseminate and communicate new scientific evidence. But it is also a way for people to communicate evidence that's not so scientific. Just press the next slide for a moment. And I just want to say, I put that on there because I'm thankful that although it's near impossible for some of these groups like Pinterest and Facebook and Twitter to keep up with or to try to block false information, it's almost impossible for them to block it all. Next slide. And I like this. I've talked about this before. Ira Glass is the person who runs This American Life, and he did a great presentation about what he learned from journalism. And this was his final slide. He had 7 things that he learned, and his final slide said, it's war. And what he said is, there's great stuff being written out there, but people aren't reading it. And we really need to figure out new ways to get information out. And it's true that, we may be very scientifically based and we're ready to talk about things, but they, meaning maybe people who are spreading false information, are more willing to fight for their false claims than many of us are willing to fight for facts. Next button. I thought this was a neat quote from Renee DiResta from the Stanford Internet Observatory that said that that's the asymmetric passion. People who believe it's going to hurt you are out there talking about it every day. They're driving hashtags and pushing content and doing everything they can do. Next slide. Next. There you go. Who's done a great job talking about all of these social influencers is the New York Times. And this was a fascinating article published on August 1st, 2021. And I was interested to find out that the White House has enlisted an eclectic army of more than 50 Twitch streamers, YouTubers, TikTokers, and the 18-year-old pop star Olivia Rodrigo, all of them with enormous online audiences. And state and local governments have begun similar campaigns, paying sometimes local micro influencers up to $1,000 a month to promote the vaccines. Next slide. And then out of the COVID epidemic, really amazing influencers have arisen. And this Black Coalition Against COVID has really done some amazing work. Reed Tuckson and Rhea Boyd, this is a great article that if you want to stick it in there, Talisa, have done some amazing work to really kind of focus on the Black community and some of the concerns related to hesitation and mistrust of the medical system. I'll have a couple quotes from them in the next couple of slides. So I don't have a big following group, but a lot of us went out there and tried to be influencers of our own. Many of us posted pictures of us getting our vaccine. But it's risky, right? Because sharing, it's risky and it's powerful. Sharing the narrative of clinicians getting vaccinated can help fight anti-vaccine propaganda. However, it doesn't come without risks. And, we learned this at MD Anderson where, we tried to run an HPV campaign. And honestly, even though we tried to be pre-prepared for negative comments, it was hard to keep up for that. And if you're interested in that, definitely tune in, I think, Tuesday, Wednesday, Thursday, I can't remember which day it is, to hear a little bit more about social influencers and how they can really impact a whole practice. So sharing our personal stories presents risks. But hopefully good stories build on each other and you've got something that goes beyond the antidote. And that's where it can become powerful. Next slide. So I think one of, as an oncologist, one of the places where it's been really helpful to get involved, and I think that's true for, I know Texas Children's has done this, and really finding survivors to partner with, because it's really hard for somebody to be against a survivor. Survivors learn so much from telling their stories. They get so much impact from this. And I think that that's one of the places where we can really impact as influencers. So all of the people on this slide are are amazing survivors of HPV-related cancers and really have done good work in trying to share their stories. In addition, where can we help them being influencers is that survivors that know that their cancer is caused by HPV, and believe me, they don't all know that, are more likely to vaccinate their own children. And they're also more likely to be aware of the vaccine's effectiveness and recommend the vaccine. Next slide. So I thought this was interesting, again, just about the power of the media being against people who are trying to speak out. This was about, I'm not going to be able to say her name right, Maya James, a New York-based wellness influencer who recently posted about watching her follower count tick down by the hundreds in real time after she posted about vaccinating her own child against COVID. She shared a screenshot of one of the emails that she received, and one of them said, "Go to hell. It's likely why so many bloggers in the space have been silent on the topic, even the ones I know of who have taken the vaccine themselves." Next slide. So, you know, I'm not asking us all to get out there and start our own influencer page, but I think we are in our own way. I think, you know, that's exactly what the Texas HPV Coalition is trying to do. And there's some beautiful other groups like the Vaccine Confidence Project and the Latino Coalition Against COVID. And really what's key for all of this is to select your niche, to optimize your social media profiles, to create an engaging bio. You can always add a profile pic, which I put some of them up there. And it's really about understanding your audience. And I want to mention in the next couple of slides, don't switch yet, but that the WHO brochure on how to talk up to anti-vaxxers or vaccine hesitant individuals is really key. And so go ahead and turn to the next slide. And this is from, this link is from the WHO book, which is just fantastic if you haven't seen it. But, you know, as we know, not everybody who comes in and says that they're not sure, they haven't been vaccinated, is anti-vaccine. There's a very low percentage that are not going to you know, they're going to be vocal vaccine deniers or complete refusers. The majority of our people are going to be hopefully vaccine hesitant, who really just need some facts. And so next slide, those are the people, according to the WHO, that we need to engage in. Rule number one, the general public is your target audience, not the vocal vaccine denier. And that's something that we can get trapped in a lot of places. Engaging in even in a chat box or in a response to an article is really giving them the respect that they don't deserve by bringing up negative comments. So stick to the facts, stick to being an influencer by posting facts, don't engage, aim to unmask the techniques that the vocal vaccine deniers are using and correct the content of their messages just by dropping facts in the box. Foster resilience among the audience against anti-vaccine sentiments and stories, and strengthen those who are vaccine hesitant. Support those who intend to vaccinate in their decision to accept the vaccine. Next slide. So this is the most important thing that I've learned during speaking to people about vaccines during the COVID pandemic. And I think it's different, a little bit different than HPV in that, you know, we always desperately want to protect our patients and the children of our patients. And somehow the pandemic has a slightly different twist in that you're also so darn tired of the pandemic itself that you just want it to stop. So when you meet somebody who hasn't been vaccinated, you're like, why? And so the most important thing is to consider managing your state. Next slide. I'm wrapping it up. So take a deep breath and just hear people out. It's, you know, I've come a long way since the pandemic started, and I usually just smile and say, hey, I noticed you haven't been vaccinated. Are there any questions I can ask you or answer for you about the COVID vaccine? You know, I'm vaccinated. I've vaccinated my parents, my children. So let them know that it's okay to have questions and that having questions and concerns is legitimate. And this is all from, this is Reed Tuckson who said this. He's from the coalition that I mentioned earlier, focusing on Black individuals against COVID. And let people know that they have a safe space to open this conversation. Wagging your finger against somebody is not useful. And it's kind of the same thing as talking to your teenager, right? If you just jump in there and tell them, you know, what you think, they may not listen. Next slide. So it may take several conversations. Science alone is not going to change the mind of those with strong beliefs. Making people feel guilty and stupid about asking questions are definite no-nos. You need to find safety and rapport. Next slide. A couple more points. Validating their concerns without judgment before offering facts. Misunderstanding of the ingredients and problems for some, moral obligation to compulsory vaccination. And many of this may come out of, you know, cultural biases. And there's a great article that I stuck in there about the history of sterilization in the United States. And that's maybe where a lot of the fertility concerns come from. Address concerns and be aware of their cognitive biases, and avoid using the word but, and consider using instead, you know, I hear your concerns and though, or I hear your concerns at the same time. We could also look at this, and could we look at it from a different angle? Next slide. I'm not gonna, I think I'm running out of time, but this slide will be available. Motivational interviewing tips are always important. We want to validate their concerns, reflect their concerns, say, I hear what you're saying, and though, could we look at it this way? Non-judgmental responses, open-ended questions, curious, non-threatening questions, and listening to the answers. And ask permission before providing information. Hey, you know, I see you still have some concerns. Would you mind if I shared some information with you about what I've learned? And most important, empower them to protect themselves and the people around them. Next slide. And for the sake of your own sanity, assess when you're not being heard and move on, because there are a small percentage of people who are not going to listen to you. And, you know, don't beat yourself up. Next slide. I wanted to put this in here because this is the most fantastic article that I have seen late at all about how to respond to the anti-vaxxers. It is a digitally active article in the New York Times. When you go in, it actually does what a lot of, I think even Laura Saviz's group has done with some of their photonovellas and things like that, where you click your response and it tells you how to like respond and why maybe the way you picked isn't a great article. Really fantastic, especially if you missed your family during the Thanksgiving holiday and you got to get together with them during the winter holiday and you have some vaccine hesitant people. Try this first. Next slide. And I wouldn't be me without throwing in some yogic wisdom here. So there's this thing called locks and keys in Patanjali's Yoga Sutras, and he talks about ways to keep yourself sane. He says that there's 4 types of people or interactions that you can have, and there are 4 types of ways of responding to them. And by responding in these ways, you will be able to keep yourself sane. So if you have an encounter with someone that's characterized by happiness, approach them with friendliness. If you have a happenstance that's characterized by sorrow or maybe just a little distress, respond with compassion. For those people who performed a good deed, like they got themselves vaccinated or they got their grandparent vaccinated, show gladness and pride. And if you have people who performed a bad deed or is cruel or just need to walk away, non-reactivity is the best response. Next slide. That's it. Thank you so much for listening, you guys. Everybody on this, the workshop today did such a fantastic job, and we've got such an amazing next 3 days after today. Please tune in every day, and I'll turn it back over to Tralisa. And if you guys have, if anyone who's on the call has any interest in joining a provider education work group, please reach out to me or Tralisa. We would love to have you. Thank you.
Thank you so much, Dr. Ramondetta, for a great presentation. I did drop the links to a couple of those articles in the chat box for everyone. I know we're over, so I don't want to take up too much time, but I am going to drop a link to our session, our post-session survey. So please take a moment to complete this survey. Let us know your thoughts and feelings about today. We'll have one for each session. Again, excellent job to each and every one of our speakers. Thank you all for participating. Thank you for joining. I'm really excited about the next 3 days. Tomorrow, we will begin again at 10 a.m. Until 11:30 a.m. And it's going to be led by our advocacy and awareness work group. So we're going to look into what's going on in our community, what's happening. And so we're really excited to hear from our speakers tomorrow. But I want to thank the Provider Education Work Group for such a great job today. You all have done amazing work, and I look forward to hearing some of those ideas that were used or provided to us using the Padlet app. Look forward to talking about those and seeing how we can move forward in our 2022 with some of those ideas. So thank you again for joining, and I look forward to seeing you all again, hopefully for the remainder of the week. Tomorrow morning, we'll be back. Enjoy the rest of your day. Also, the slides will be provided to you all. Once we wrap the entire summit, we will provide all of these slides for you all to have. Thank you. We'll see you in the morning.
Thank you. Thank you, everyone.
Thanks. Thanks, Teresa.